If you're drawn to the heart, you eventually have to answer one question. Do you want to manage it or operate on it? That answer determines everything from the training to the lifestyle to the kind of doctor you become. Dr. Jubal, MedSchoolInsiders.com. For this career battle, we're putting cardiologists and cardiothoracic surgeons head to head. Training, competitiveness, compensation, lifestyle, and what it actually feels like to live inside each of these careers. If you're drawn to the heart but haven't decided which side of the scalpel you want to be on, this one's for you. Cardiologists and cardiothoracic surgeons both spend their careers on the heart. They round in the same hospitals, sometimes on the same patients, and they consult each other constantly. But the relationship is more like a handoff than an overlap. When the cardiologist reaches the limit of what a catheter can fix, the CT surgeon takes the call. That said, the line between these two careers is blurrier than it once was. Cardiology has become increasingly interventional over the years, with non-surgical procedures now handling conditions that used to require a surgeon. On the surface, these look like very different careers. In practice, there's more overlap than most students expect. Cardiologists are the physicians of the heart. They diagnose and manage conditions like coronary artery disease, heart failure, arrhythmias, and valve disorders. Some perform invasive procedures, threading catheters through arteries to open blockages, implanting pacemakers, or ablating rogue electrical pathways. But the chest stays closed. That's the line. Cardiothoracic surgeons cross that line for a living, performing open heart surgery, bypass grafts, valve replacements, lung resections, and transplants. When a patient needs something fixed that only can be reached with a scalpel, that's the CT surgeon's domain. Cardiology sits at a rare intersection of medicine and procedure. It's procedural enough to satisfy surgically minded doctors, and medical enough to satisfy those who love the intellectual puzzle of diagnosis. CT surgery is less ambiguous about what it is. Operations are long, patients are sick. The culture, while improving, has historically been one of the most demanding in medicine. It attracts people who aren't afraid of hard work, which is a polite way of saying it filters out most people who try. The paths to these two careers split early, and they split hard. To become a cardiologist, you start with a 3-year internal medicine residency. Internal medicine is the most common residency and the gateway to many subspecialties, including cardiology, gastroenterology, pulmonology, and oncology, among others. After residency, the cardiology fellowship runs another 3 years. That's 6 years of post-medical school training before you practice independently, and that's often just the beginning. Interventional cardiology, the subspecialty focused on catheter-based procedures like angioplasty and stenting, adds another year of fellowship. Electrophysiology, which deals with arrhythmias and device implantation, typically adds 1 or 2 more. Heart failure and transplant cardiology carries its own fellowship requirements on top of that. The subspecialty you choose shapes not just what you do, but how you live. For cardiothoracic surgery, there are 3 distinct training pathways, and choosing between them is one of the first major decisions an aspiring CT surgeon faces. The traditional independent pathway runs 5 years of general surgery residency, followed by a 2-year CT surgery fellowship. You graduate board certified in both general surgery and CT surgery, having spent 7 years beyond medical school to get there. The integrated pathway compresses this into 5 to 6 years at a single program, with rotations split across general and CT surgery, but graduates are only certified in CT surgery. This is generally the most desirable and competitive of the paths. The combined or fast-track pathway blends 4 years of general surgery with 3 years of CT surgery at a single institution. Graduates come out certified in both. Most aspiring CT surgeons want the integrated pathway because it's shorter, but limited spots push many toward general surgery residency first. However, don't think general surgery is an easy fallback. It ranks 8th out of 23 specialties on specialtyrank.com. After completing CT surgery training, further subspecialization is possible. Congenital cardiac surgery, transplant surgery, thoracic aortic, and endovascular surgery each add another year. Congenital cardiac surgeons frequently operate on neonates, working on a heart the size of a golf ball, sometimes within hours of birth. Both are among the most competitive fellowship tracks in medicine. The Cardiovascular Disease Fellowship is the largest fellowship match in internal medicine by volume. In 2026, 1,347 positions were offered across 292 programs, and every single one was filled. That's the 5th consecutive year it's hit 100%. The catch is that 2,141 applicants competed for those spots, so more than 1 in 3 didn't match. For CT surgery, the integrated pathway, commonly called the I-6, is its own bottleneck. In the 2026 main residency match, 56 integrated thoracic surgery positions were offered across 39 programs, and all 56 were filled. On the program side, that's a 100% fill rate. On the applicant side, 110 people competed for those 56 spots, meaning roughly half didn't match. For context on the general surgery pathway, which most CT surgery applicants go through, SpecialtyRank.com ranks it 8th out of 23 specialties. Successful applicants average a Step 2 CK score of 253 and 10.9 research items. If you're targeting either of these careers, research output, board scores, and clinical reputation need to be priorities from day one, not something you piece together in your final year when fellowship applications are already open. Thoracic surgery averages almost $690,000 annually, second only to neurosurgery among all specialties. Cardiology comes in at nearly $590,000, 8th on the same Doximity list. The $100,000 difference looks like a clear win for CT surgery until you look at what's inside the cardiology number. General cardiologists pull that average down. Interventional cardiologists and electrophysiologists earn considerably more. And at the subspecialty level, the compensation gap between these two careers is much smaller than the top-line figures imply. What that salary comparison misses entirely is opportunity cost. A cardiologist finishes fellowship 1 or 2 years before a CT surgeon does. That's 1 or 2 additional years of fellow pay before a CT surgeon sees an attending salary. Fellow pay at most programs sits well below 6 figures, while attending pay does not. That's a real difference in lifetime earnings, even if the annual salary figures eventually converge. Cardiology's lifestyle depends almost entirely on which cardiologist you decide to become. General cardiologists and heart failure specialists often build relatively predictable schedules, mixing clinical with hospital rounding and following patients over years. That version of cardiology is sustainable in a way many specialties aren't. Interventional cardiology is a different story. STEMI alerts, which are heart attacks requiring emergency catheterization, don't follow a schedule. When the alert fires at 2 a.m., you go. The lifestyle of an interventional cardiologist isn't far removed from that of a surgical subspecialist in terms of call burden. And here's something worth sitting with before you commit to that path. When you're in your 20s, overnight call and sleep deprivation seem manageable, as with most things at that age. Think carefully about what you want your life to look like at 50. A 4 a.m. emergency hits differently then. CT surgery is less ambiguous. Operations are long. A standard coronary bypass runs 4 to 6 hours. Complex cases, reoperations, and transplants stretch well beyond that. Transplant surgery offers no predictable schedule at all, as organs don't wait for business hours. When a donor becomes available, you go, sometimes across state lines, sometimes in the middle of the night, and sometimes both. Even outside emergencies, CT surgeons at busy programs face consistently long weeks. This is the career where, as the saying goes inside medicine, you make the most money, but don't have time to enjoy it. This is a reality worth taking seriously before you commit to a path that doesn't get much more manageable once training ends. Cardiology sits at a rare intersection. It has the intellectual depth of internal medicine and the procedural satisfaction of surgery without requiring you to pick one. The physiology is endlessly interesting. Fluid dynamics, pressure gradients, and the elegant logic of how the cardiovascular system compensates when things start to go wrong. It's a field that rewards curiosity over a 30-year career rather than burning through it. And unlike specialties built around memorizing long lists of facts, cardiology tends to reward people who understand how systems interact, which makes the learning more durable and the work more satisfying over time. The breadth of subspecialties means that you can build a career around your personality rather than forcing your personality to fit the career. If you're procedure heavy and adrenaline driven, interventional cardiology is built for you. If you'd rather manage complex chronic disease, heart failure is its own world. If the electrical system of the heart is what keeps you up at night, there's electrophysiology. Not many fields give you that kind of range under one roof. The technology is moving fast too. Transcatheter aortic valve replacement has already transformed how aortic stenosis is treated, just as coronary stenting changed bypass surgery before it. In a few years, opening someone's chest to replace a valve may look as outdated as older surgical techniques do to us now. If you want to be part of a field that looks meaningfully different every decade, that's cardiology. That said, heart failure is a progressive disease. You'll have patients who follow every recommendation and still decline. End-of-life conversations are a regular part of the job, not an occasional one. That emotional weight accumulates differently than it does in specialties like ortho, where you fix something and the patient walks out. And it's resulted in a 38% burnout rate in cardiology in the US. Interventional subspecialties carry occupational radiation exposure that compounds over a career. It's a consideration that gets far less attention than it deserves during training, and by the time most physicians think seriously about it, they're already years into a high-exposure practice. Plus, the pipeline is long, with a minimum of 6 years beyond medical school and more if you subspecialize. Where else can you feel someone's heart beating in your hands, stop it, and then bring it back to life? That's a regular Tuesday for a CT surgeon. And even when the cases become routine, the fact that they become routine doesn't make them ordinary. The cases are big and varied, ranging from open heart surgery to lung cancer resections to esophageal repairs to transplants. There's a physicality and technical demand to CT surgery that attracts people who want to use their hands at the highest possible level. When it works, the outcomes are as dramatic as medicine gets. A patient who came in with a failing heart goes home with a new one. The field keeps changing too. Robotic and minimally invasive approaches are expanding across CT surgery in ways that are reshaping what the specialty looks like, including mechanical circulatory support devices, artificial hearts, and next-generation valve technology. The surgeons entering the field now will practice in an OR that looks substantially different in 20 years, and they'll have had a hand in building it. And unlike some surgical specialties where you operate and then disappear, CT surgeons manage their patients throughout the hospital course, including ICU care, recovery, and follow-up. It adds an intellectual dimension that balances the intensity of the operating room and keeps the work from becoming purely technical. But CT surgery comes with serious downsides. The patients are among the sickest in the hospital, and not everyone makes it. You'll deliver devastating news to families after operations that went as well as technically possible, but the outcome was still poor. That accumulates over a career. It doesn't get easier the way some difficult things do with experience. Training is one of the longest commitments in medicine. 7 or more years past medical school, often earning a fellow salary, while peers in shorter training tracks are already years into attending pay. For many people who seriously consider CT surgery and ultimately choose something else, the timeline was the deciding factor, not the work itself. Once training ends, the demands don't significantly ease. The hours are still long. The call is still unpredictable. The difference is that now you're the one everyone else in the room is looking to. It's a weight that doesn't go away, resulting in a burnout rate of 43%. Both of these careers will ask a lot from you. The training is long, the stakes are high, and neither path gets significantly easier once you're through it. The real question isn't which one pays more or which one sounds more impressive at a dinner party, but which version of a demanding career fits the kind of doctor you actually want to be. If you want to manage the heart, understand it deeply, and build long relationships with patients over years, cardiology gives you that. If you want to open the chest, hold a beating heart in your hands, and fix what nothing else can reach, CT surgery is built for that. For more head-to-head specialty comparisons, check out our full career battles playlist right up here.